practice-based evidence will give us a better chance as nurses at the bedside to really focus on what needs to be measured and measure it. And we need to get a lot of the terrible stress and terrible distractions out of the way of our patient care. Does that sound like that might be a way to go?
That sounds great to me. Yeah.
So some of it is not, perhaps we're getting service and humility confused with low self-esteem. We don't want to be, going around with big egos talking about what we do all the time, because we're serving patients. But at the same time, we have to be clear about how important what we do is. And it seems like only the patient and us know it a lot of the time, and the family. So maybe more focus on that will help us, I think.
Actually, I'm just thinking about the word value and how value has become a kind of jargon word in healthcare. But that's really what I was getting at, not a boastful point of view, but that nurses are value added rather than traditionally we're just seen as a cost center, right? Because we don't get reimbursed. And so I know there's been some work done on that, like the business case for nursing, that showing that nursing is really economically value added, but that might be a way to go with that. And
I think.
Yeah.
Thank you.
Well, and one of the, I think another important part of the work that you do is that just as you have said, it's hard for nurses to talk about what they do with patients or be boastful about what they do. And so it's wonderful that we have someone like you who writes so eloquently about the experience from both the nurses and the patient's perspective, but primarily from the nurse's perspective. A story I don't think that often gets told, or that we have a hard time telling ourselves to people, but I think your work is very reachable by people who are not in the profession at all, who can sort of peek inside peek inside something that they've never experienced.
Yeah, and I feel my proudest when nurses write to me and they say, "Thank you for telling our story."
Yeah, you got it.
Yeah, and I tell people it's not that I'm unique in what I do as a nurse. I'm unique in my ability to tell the story, and I'm lucky enough to find forums where I can do that.
Yeah.
But that's when I feel really, really proud, when someone says, "I'm not good at explaining what I do," so I'm glad that you can do that.
So I want to ask you one more question, then I'm going to the light's flashing right in my, Kenrick. Yes.
You want to go first?
No, you go first. I'm the closer.
Okay. Hi, my name is Ken Ricato. I'm on faculty of the School of Nursing, and I'm also in the law. So the question I have to ask is about PTSD. One of the reasons I'm asking is because I'm also a veteran, and I was in the military before I became a nurse. And one of the things I noticed very quickly, and you touched on it in the chapter, in this excerpt that you read, was that like a combat situation, in nursing things can change very quickly. And I think that leads to, possible trauma. And so I was wondering but fortunately for veterans, you have like support groups and things like that. But nurses don't have similar types of setup. So I was wondering if you thought that there's more that can be done in training of nurses, but also if there's any kind of structural things that can be done to help nurses deal with dealing with the kinds of trauma that they have to deal with in nursing.
Yeah, that's a great question, and this also kind of gets back to your asking me, how can we make the work situation better? Right. I mean, one thing is I wish when there was a code that any nurse who wanted to could come for 5 minutes and just talk about what happened, or at the very least that there was always a debrief with the nurse who called the code. I mean, had a friend who was a pretty new nurse, coded a patient we all really liked, and I wasn't there, but I heard about it later, and I said, well, and she wasn't sure if it had been, should she have acted earlier, just all these questions that you have. And I said, well, someone came and told you that you did a good job and you did the right thing, right? And she said, no one said anything to me. And that's so typical and so terrible, because then you live with these doubts, and sometimes you hear, once I heard the ICU nurses out in the hallway after a code on another floor saying, so why were we called to that code? And just, nobody needs that. You need to talk about what's appropriate and what's not. So that's one thing, is taking time to debrief, and again, getting back to, can you have someone take your phone for 15 minutes? Like nurses would say, there's no place we can go to just sit quietly for 10 minutes. And sometimes it seems like that, and that alone would make a big difference. I also was talking at University of Missouri Columbia once to their oncology group, and asked, well, what do you do in your workplaces? And at one place they said every time a patient dies, they have a meeting that any of the nurses can come to. I mean, it'd be great if the physicians would come too, but you could come to, and everything's fair game. You can say that you love the patient, you can say they drove you nuts, you can tell a story about them. And I thought, that is such a great idea, because we would have deaths cluster, and it was, we would talk to each other, but to have some formal grieving process like that could really be huge. But instead, I think we learn, suck it up, don't let anyone see that you have feelings, and if that worked, it would be great, but now we know that leads to burnout and people quitting and bad stuff.
So last question. Oh, there is this huge spotlight that's blinding both of us, so we cannot see you.
Hi, my name is Jacqueline. I'm a nursing student in the nurse practitioner program. Thanks for being here. I had a question. I haven't been a nurse very long, but when I first started, I remember one thing that I didn't learn in nursing school was all the different hats that nurses wear, and all this pressure that you have to coordinate everything. And like I noticed it one day when I was on the phone with a pharmacy, calling 12 different pharmacies to see if they had a drug, and I was like, this is totally not my job. But I had this feeling of this burden of trying to make all these different people happy, and then this balancing with good quality nursing care. And I didn't I obviously have developed in how I do things, but I didn't understand, like, what's more important. I'm supposed to treat this patient with all these different things, and I'm also supposed to make all these people happy, whether that's on a patient satisfaction survey or making sure the doctor has what they need or whatnot. So I was wondering if you had any suggestion maybe for newer nurses or just people in healthcare in general, how we still give that good quality healthcare and also are able to do all of our other responsibilities. Like, how do we get that balance? Like if there's any way to kind of like stress relief or just be able to provide that good care. So.
Well, at the start of the book, I do talk about being a nurse is like putting your shoulder to the huge rock that is modern healthcare and pushing it up the hill. And of course, my background in literature, you think of Sisyphus pushing, his punishment was to push a rock up a hill, and then when he got to the top, it would always roll back down. And so the feeling is every day when you come in, there's that same rock there that you have to push up the hill. What works for me is I love doing patient care, and it's very rare in a moment with a patient, even if things are going badly and they're angry, it's very rare that I feel like I'm just useless here. There's no good I can do here. There's always something that I can do, even if it's just to listen as an educated listener who understands the healthcare system. And that is what keeps me going and fuels me and is so important to me. do I have moments where I feel like this system is so idiotic, I just cannot do this work one more minute? Of course. I mean, you know, there's no job that's perfect, right? And sometimes balancing, as you say, making people happy with what's required of you, with what people really need that really matters, that can be very difficult and very frustrating. But I focus on my patients. What can I do for this person today? It may be small, it may be big. It's important, and it's why I'm there.
So one last question. I'm getting the hook. Oh, there you go.
Hi. My name is Anne Marie Brown, and I graduated from here thousands of years ago. I started the Mobile Crisis Service here, and I worked at least 30 years in mobile crisis work, which is going into homes for different reasons than you go into homes. But I wondered if you could talk a little bit more about going into a patient's home, because I'm in private practice now for 25, 30, you know, a long time. But because I did so much work in patients' home, I still do that. Or I still go to the hospital when one of my patients are in the hospital, or if one of my patients is homebound for one reason or another. There is a wealth of information, I feel, that I gain just by being in the patient's home, meeting the family, seeing how the setup is, where the bed is, as opposed to where the toilet is important issues when you go into someone's home. And I wish a lot more nurses would go into making home visits, because I have always found it very rewarding, and patients very responsive to it.
Yeah, I think that's absolutely true. I mean, I remember a very ill and overweight cancer patient who was in their downstairs family room, and I was looking, you know, trying to look around and say, where's the bathroom here? And there wasn't one. So then it's figuring out how to, and they had a bedside commode, but it was put away. So then it's figuring out how to phrase that question, because a home care nurse who was actually featured in Carolyn Jones' movie, The American Nurse, I said, give me one piece of advice, because I'm starting home care, and he said, always remember that you're a guest in their home. And that was excellent. The other thing about it is it really is a leap of faith. I remember at the start going to some of these homes, because outside Pittsburgh it can get fairly rural fairly quickly, and I remember this one house, it was off a gravel road, and this really long driveway, and I thought, am I insane? What am I doing here? Just, it was a modern house, but there weren't any windows on the wall I was coming up on, and but actually the family was great, and I think that was the moment for me when I realized, okay, I have the trust to do this job. So if you start out with some insecurity, you got to give yourself a break about that. I think that's normal. You know, if it lasts, then it may not be the job for you. But yeah, you do see a lot. You definitely do.
So like all of our students, at least our recent students, you all chose nursing after doing something else from some other career, as did you. Mm-hmm. And I think in nursing we are grateful that you made that decision, but also that you brought this ability to tell a story with you. So Theresa, thank you so much.
Aww.